Good evening. At the onset, I thank the organizers of this annual conference, very beautifully organized one, for inviting me to chair this session. Nowadays, we are facing the management of diabetes. We have got a lot of controversies in managing diabetes, especially with the diabetes, with the obesity. Obesity is one of the complicating factor in the management of type 2 diabetes. Most of the pharmacological therapy in type 2 diabetes is associated with some sort of weight gain or weight loss or even without any change in weight. But we prefer most of the pharmacological management with weight reduction, especially in obesity patient with the type 2 diabetes. We have a wonderful drug, wonderful or not, we can discuss about Canagliflozin. But we don't know whether it can be an initiator in pharmacological management or as an add-on therapy. We have an eminent speaker, Dr.Hemant P. Thacker. Today we are discussing about the topic Canagliflozin, where can we place in the therapy of type 2 diabetes. Dr. Hemant P. Thacker is a consultant physician and cardiometabolic specialist in Breach Candy, Jaslok, Patia, Saifi and Motiban Dalvi Hospital. Okay. And he is a chief medical advisor of Times of India, and he is a principal investigator of more than 35 international, multicentric and national and other studies in India and abroad. He is a co-founder of faculty expert of Pre-Disease Forum, an international initiative with members from all over the world, launched at the IDF in December 2011. I invite you, sir, for presenting this topic.
Is the color mic on? Good evening, ladies and gentlemen. After that giant talk from Tiny Nair, it's time to invoke diabetes again and leave cardiovascular metabolics separately. I'm going to talk on Canagliflozin, which is a new group of drugs. And let me lead you up. This doesn't work, the remote. Slide changer. All right, then I'll have to do it from here. Does it work? So we are here to see after metformin. Okay. After metformin, let's look at other evolving combinations for therapy. I'm using the word combinations because metformin still is the soda of the oral diabetic cocktail. So what do we really have for that? As we know, the numbers in diabetes are only increasing. I don't think I want to bore you with the shocking numbers, but the fact remains that diabetes in India, look at the last point, more than 1 crore of deaths occurring every year. There is the rule of halves, where half the diabetic patients in this country are not diagnosed. Of the half that are diagnosed, half do not get treatment. And of the half that get treatment, only half reach target. And of the half that reach target, only half maintain it. So the tragedy of this evolving problem is that you have to live with diabetes. You have to walk with it, not chase it. Once you are able to live and accept diabetes with the appropriate therapy, then you know where you can get. We know that the incidence of clinical complications is strongly associated with the severity and the duration of glycemia. And there is irrefutable importance of glycemic control from the time of UKPDS. And each 1% reduction in A1C is associated with an overall drop in endpoint of 21%, 21% of deaths, 14% of MI, and 37% of microvascular complications. We also know that monotherapy almost always progresses to combination. Within 3 years of diagnosis, more than 50% of patients will need more than one drug. And after 9 years, approximately 3/4 of the patients will need multiple medication to achieve the 7. So what is this wish list for 2015? How do we tackle it? To take you up this ladder, you can see that it began with the metformins and the biguanides and the sulfonylureas. And as it went up, top on the list today is the SGLT2 inhibitor. How has diabetes regularly been treated recently? The traditional approach was the guideline or treat to failure. You treat till the drug fails and then you go to the next step, which is a sequential addition with more established use. The approach 2 is the pathophysiologic, an initial combination therapy with agents known to correct established pathophysiological defects in type 2 diabetes. But there is a combination of 1 and 2 where you take age, body weight, complications, duration of disease, life expectancy with expense, education, and etiology. And in doing that, you have to conquer the triumvirate, which is impaired insulin secretion, decreased glucose uptake, and increased hepatic glucose production, causing hyperglycemia. So you need a brainwave to attack this. In the natural history of diabetes, this graph clearly shows you that as the insulin levels start decreasing, you get a worsening of sugar control. And then the natural history of the beta cell is that beta cell failure occurs much earlier than it was thought. And we have seen that when patients come to diagnosis, more than 80 or 85% are living on the edge with no beta cells. Look at the fasting plasma glucose and concentration and relative beta cell volume in obese subjects with normal glucose tolerance, impaired fasting glucose, and type 2 diabetes. And you can see that the beta cell volume is sliding down and the sugars are going up. So the summary is that patients with IGT are almost maximally insulin resistant, more than 80% of beta cells gone, and have lost a very large significant proportion of beta cell mass. They already have developed retinopathy. So in doing this, you have to intervene early. And interventions should be targeted at the pathogenic mechanisms known to promote beta cell failure and cause insulin resistance. We all know this ominous octet. I do not want to go into it. It's very pictorial. And we know that this is the 8 figures of hyperglycemia. Neurotransmitter dysfunction was missing, which we just threw in. Now, in the treatment of type 2, therefore, we need a concoction, a cocktail, to correct the multiple pathophysiologic defects, and should be based upon known pathogenic abnormalities and not simply with a view to reduce A1C. And it must be started early in the natural history of type 2 diabetes if progressive beta cell failure is to be prevented. So you need a cleanup operation. And how do you do that? The treatment is based, you can use the TZDs and metformins at these levels, the TZDs at the other levels, GLP-1, sulfonylureas, DPP-4s. You can use all the other, as you can say, different drugs. But there are certain newer approaches. And it's the newer approach that I want to talk about. See the effect of sulfonylurea and metformin, which is your traditional mainstay. There is gradually, with this conventional treatment, a failure with an excess glycemic burden. As the years chug along from treatment, by the time you are at 5th, 6th, 7th and onward going, there's going to be excessive glycemic burden. Because the durability of glycemic control with sulfonylureas is slowly but surely going to weaken. The same thing we see even with metformin, where you see secondary failures of metformin monotherapy. So we are finding that durability is less. What are the newer drugs that we have? We have incretins. This is how incretin works when you give an oral load of glucose. We have DPP4 inhibitors, where you can see how DPP4 inhibitors work up to about 0.5 to 0.9 A1C reduction. But it is this new SGLT2, a novel strategy for type 2 diabetes, which is holding center stage today. These are the different compounds that are available. On the right are the ones that are under investigation. Look at the renal handling of glucose. Almost 90% of all the glucose that is filtered out into the tubule is absorbed by the sodium-linked glucose transporter 2. And it is picked back. And the remaining 10% is reabsorbed by the SGLT1. So the SGLT2 is the co-transporter which picks back the glucose which has been filtered out into the tubule, as a result of which no spillage of glucose occurs in the urine. Now, how does the renal contribution come in? You know, there is also neoglucogenesis in the kidney, and there is glucose reabsorption. And if you total this, it can come to a very significant amount. How does canagliflozin work? And why should we look at the kidneys to treat hyperglycemia? The normal kidney, there is a plasma glucose around 180 when this reabsorption occurs. And this reabsorption, as the glucose goes down the tubule, is picked up back by the SGLT2, the receptors, and it goes back into the blood. So therefore you have no glycosuria. Now, canagliflozin reduces the renal glucose reabsorption by blocking this SGLT2, and therefore it increases urinary glucose excretion. It intentionally causes glycosuria. And as you see here pictorially, there is a blockage. So very little gets picked back and more glucose goes down, resulting in a loss of anything from 90 grams to about 180 grams of glucose. There is glucose reabsorption which is decreased into the systemic circuit, urinary glucose excretion increases, and blood sugar levels fall. If you look at renal glucose handling, this is the classic physiology where at these levels there is a theoretical threshold and the urine starts getting contaminated with glucose because there is the threshold which is crossed. This reabsorption begins as early as 100, but really the excretion starts after a level of 180. So the aim is the body wants to conserve the glucose. This is a graphic showing of what happens in animal models. The renal tubular glucose reabsorption, which has been mimicked in animal models to show what happens in the diabetic. In the diabetic, there is increased renal glucose handling. And in order to conserve the glucose, the threshold becomes higher. The patient does not spill it into the urine, and there is more avid pickup through the SGLT2 to conserve the glucose. And this avid increases the threshold and takes it down. This is at the non-diabetic level, and this is in the diabetic level. So the renal glucose handling shows that excretion then starts at levels of 220, while at these levels there is an avid pickup by the SGLT2 receptor. Why does this happen? This happens because there is a greater expression of the SGLT2, because the body wants to conserve the glucose and not spill it out. So this is where the idea occurred, that if you have more spillage in the urine and less reabsorption, you will be able to, in crude terms, pee out your extra glucose. So what happens? Canagliflozin lowers this renal threshold. It drags it back. As you can see, it is pulled back by canagliflozin. So you start spilling the glucose in the urine at normal levels or earlier than the diabetic levels, because the diabetic level has moved to 220 and beyond. So it brings it back. So you start passing more glucose in the urine. And this more glucose in the urine is not reabsorbed because the SGLT2 is inhibited, competitively inhibited. So not only does it invoke more spillage in the urine by pulling back the threshold, but all that has been secreted into the tubule is not reabsorbed because of the SGLT2 blockage. So renal tubular glucose reabsorption, which is increased in type 2 diabetes, what do SGLT2 inhibitors do? They inhibit this glucose reabsorption. The resultant glycosuria leads to a decline in plasma glucose. And when plasma glucose comes down, there is reduced glucotoxicity. And this reduced toxicity is independent of insulin. This is an insulin-independent drug. And the beauty of the therapy resides in its simplicity and non-specificity. You could be type 1, you could be type 2. You will spill out into the urine, and what you spill out will not be reabsorbed. And this is what SGLT2 does. Even the most refractory to treat diabetic patients will respond. I am not saying that you can use it for type 1, which is currently an off-label indication, but definitely it has seen good results. Canagliflozin was the first world's approved SGLT2. It significantly lowers HbA1c, whether you give it 100 milligrams or 300 milligrams. It also dropped the fasting and the post-lunch sugar significantly. It reduced weight. Why did it reduce weight? Every gram of glucose is 4 kilocalories. If you spilt on an average 100 to 150 grams of glucose in the urine, you're again peeing out your calories, so there is weight loss. And this, if you compare it to your traditional glimepiride, you can see over 52 weeks, the action is same, comparative, maybe better. So therefore, the body weight changes for the better, the body fat goes down, subcutaneous fat goes down, visceral fat goes down. And the weight reduction is due to loss of not lean body mass, but fat mass. So therefore, your toast is buttered on both sides. Your sugar comes down, your weight comes down. If you compare it with sitagliptin and metformin, with canagliflozin and metformin, you see the results are comparative, at some stages even better. So you can see that both of them put together had a good drop. If you look at blood pressure, there was a positive impact on blood pressure. There was a volume reduction. It's like a diuretic because you're pushing out glucose and there's osmotic diuresis. So a systolic drop and a diastolic drop. And this was also seen on a background of other medication. So you can see that canagliflozin, even up to stage 3 of chronic kidney disease, where the eGFR is more than 30, it did work, after which, when you halved the dose, you could not give it. If you look at the durability, this is a 104-week study compared with glimepiride. Canagliflozin in 100 milligrams served the purpose. Effective, durable, long-standing. No hypoglycemia, because at a particular level, there was no spillage in the urine because your threshold was reached, as a result of which there would be no hypoglycemia. Compare hypoglycemia of glimepiride with canagliflozin, nothing. So this was done in placebo-controlled studies, body weight was done in placebo-controlled studies, systolic blood pressure was seen, and literally the results of this blew everything away. Here was a drug which reduced weight, reduced blood pressure, reduced glucose, and still was effective independent of insulin. So, what are the CV risk factors which Tiny Nair talked about? It decrease in systolic, diastolic blood pressure, improved glycemic control, reduced weight, change in fasting lipids. I must point out there was a slight increase in LDL here, but not small dense LDL. Of course, the cardiovascular results will come out with the Canvas study. It has been used as monotherapy and shown good results. I'm not advocating monotherapy. I still believe it should be after metformin. What about adverse effects? When you pass lots of glucose in the urine, you're going to have urinary infection if you're not hygienic. You're going to have fungal infections if you do not observe vulval hygiene. But this is theoretical. Look at the incidence. The genital and the genitourinary infections were not something horrible to worry about if the patient was well educated. And the results with placebo were not alarming. And educated patients were able to overcome all these problems. There is one thing that I need to point out is volume-related adverse events. If a patient is on a diuretic, you'll have to be careful giving him canagliflozin because there is going to be volume diuretics. So you will need to adjust for systolic blood pressure, volume, adverse events. This is actually a copying of the inherited disorder of renal glycosuria. But what happened in renal glycosuria? There was no problem, no kidney failure, no fungal infections. If you saw patients with renal glycosuria, the histology was normal, renal function was normal, CRF was not increased, incidence of UTI was not increased. So cut, copy, paste renal glycosuria, a genetic disorder, and precipitate renal glycosuria using canagliflozin, and you have a similar picture. So I think SGLT2 inhibition probably meets the unmet needs. It corrects a normal pathophysiologic defect. There is reversal of glucotoxicity. It reduces A1C, produces weight loss. It complements other anti-diabetic agents, also reduces blood pressure. There is no hypoglycemia, and overall improves glycemic control with CV risk factors. So favorable, everything looking good. It's been around fairly long. In India, I have been using it for the last 3 to 4 months. I did the clinical research study on this, and we found very good results, provided you educated your patients about renal glycosuria and about urinary tract infections. Probably this will change the game the poor diabetic has to play. Thank you for your attention.
Thank you, Dr. Hemant P. Thacker.
I have one other slide, if you permit me. This is a slide which is my favorite slide when I presented, that this is what canagliflozin does, and that's all the glucose here. And coming from Maharashtra, where we have sugar factories, I'm quite sure the Indian sugar merchants will collect the urine of all these patients and have an ancillary industry once they use canagliflozin. Thank you.
Thank you, Dr. Hemant P. Thacker, for an excellent presentation and clearly point out the role of canagliflozin in weight reduction and HbA1c reduction. The topic is open for discussion. Any doubt you can clear.
How is it different from dapagliflozin?
Very good question. Both are SGLT2 inhibitors. But there is a small study which I have, I could show you later on, a head-to-head comparison, where the effect of Canagliflozin is more durable, long-lasting, and it works also on the postprandial phase as compared to dapagliflozin. The physiology is the same, but probably one drug is seeming to be more effective than the other in this small study which I have, which is on slide. All of them, all the gliflozins work on the same principle. It's like all the gliptins work on the same principle. What makes one better than the other?
So how would you place this drug in your practice next to metformin?
Well, you can definitely use it next to metformin if you want to give it as a second line. Currently, probably it is occupying a third space after two drugs. But only time will tell. When the gliptins came in, they were the third additions 5 to 7 years ago. Today we are using gliptins soon with metformin. There will be a time where if this physiology makes you lose weight, remember gliptins are weight neutral. The gliflozins are weight negative. So if you have a drug which has all these things put in the thali, so if you don't like one, you have another, you don't have another, you have a third, everything put together, I can envisage a time that it might be used as a second line therapy.
What is the, I may add, what is the renal threshold in a patient of renal glycosuria?
It moves. It moves upwards from 160, it can go up to 200. And with diabetics, it can go to 220, 230. The aim is the body wants to preserve what it has produced. So therefore, the renal threshold goes
So
up.
I'm asking the genetic condition.
Genetic is more or less the same. It doesn't go up because the patient is born with it. Then that's his threshold with from birth.
The program is running short of time. One more question, please. One more. That question.
Will somebody give him a mic, please?
He's asking about the cost.
The cost is more or less, I think it's about 45, 50 rupees a tablet of 100 milligrams. If I know it right, Invokana is available only as 100 milligrams in this country. And I have seen very good results with 100. I don't need to go to 300. But if I think the manufacturers will tell you, but it's around 50 rupees, I think. Yeah? 51. All right, there you are. In these days of iPhone and internet technology, the value of 1 rupee is only in Modi's parliament, which is the cost of chicken biryani.